Okay, great. It is my distinct honor and privilege to introduce our speaker today. Dr. Eve-Lynn Nelson is a professor in the Department of Pediatrics, University of Kansas, and executive director of the Telehealth ROCKS and Heartland Telehealth Resource Center. She began at Kansas University Medical Center after completing a pediatric psychology internship at the University of Miami Jackson Memorial Hospital and graduating from the clinical psychology program at the University of Kansas. Dr. Nelson has pioneered school-based telehealth from 1999 to the present, and she is an expert in child telebehavioral health. Her team's multi-state Telehealth ROCKS KanAWARE initiative extends behavioral health best practices and social services supports to set all students up for success in the classroom and in life. She is proud to lead the Heartland Telehealth Resource Center and support the dissemination of telehealth best practices. She has had the privilege to provide telepsychology services for over 25 years and energize the next generation of healthcare providers and researchers to partner with communities and leverage technologies to solve big problems together. So with that, thrilled to introduce Dr. Nelson, and I'll turn it over to her.
Thank you. I appreciate the warm introduction and the chance to work with your team. I'm really excited to talk together today about how we leverage telebehavioral health to extend services to youth and families. I always like to start off. I'm very lucky to work with families across the region and really share my admiration and appreciation to my team, our participating families, community partners, academic collaborators, and our funders. Today we've got quite a bit on our plate. There's three objectives that we'd like to cover today. First off is to review the rationale for child telebehavioral health. Second is to discuss the competencies associated with telebehavioral health with children and families. And then the third is to share ethical best practices in child telebehavioral health. First off, with a clinical care example and talking some about our telefeeding team. And then second, where we're using telebehavioral health as part of a larger family school community partnership, which is our program, the Telehealth ROCKS program. So with this slide, I know it's a bit singing to the choir. At this really busy time of year, I think we're all coming together today because we really see the challenges our children and families are facing and really the struggles and suffering that they're facing. We see that uh, many adults and children face a mental health crisis, with 90% of the public thinking there is a mental health crisis. A third of all adults reporting that they have felt anxious either always or often in the past year, and a third of respondents sharing that they could not get mental health services that they needed. This the flip side of that coin is with children, we see really a national crisis around mental health, really concerning increases in childhood depression, anxiety, loneliness, and at the most severe and really concerning increases with suicide risk. So in coming together today, we're trying to think with this big crisis and challenge, we do have good solutions for children and families. So we'll talk together today about what's some big solutions, how do we leverage our technologies and our telehealth to be a piece of the solution around this really concerning crisis. I'm going to talk a little bit about rural child health. Um, we, of course, can leverage our technology and telehealth to serve children across geographies, but especially in my region with Kansas, Missouri, and Oklahoma, we see a lot of telehealth with rural children and families. So when we think about comparing our urban and rural child peers, we see that With rurality, it's associated with greater overall risk of morbidity and mortality across that child age range. We see that there are increased risks for child injuries, increased risks for environments and living situations and environmental risks that are associated with poor health. We see higher frequency of ACEs and more risk in rural areas with rural children and families for separations, divorce, parental death, family economic hardship and poverty, violence, greater risk for incarceration of a household member, and greater risk of mental illness and substance abuse in households. Rural youth also have increased rates of risk for disability, obesity, poor oral health, and drug use, as well as higher rates of early pregnancy and STDs. Rural children also have a slightly higher incidence of mental, behavioral, and developmental concerns, and again, just significantly less access and use of behavioral services. So that's really part of the challenge we face and are trying to solve for with some of our telehealth. I also want to talk about there's the challenges, but also some of the strengths that our rural communities bring. And I know as we were doing the introductions, we have folks joining us from the rural communities, and I'm sure could speak to these many strengths better than I am. Um, I think there are things we can leverage and think about as we extend our telehealth services, really leaning into some of the relationship strengths that our rural areas have, the trust and value that's placed in community and helping one another, um, and really values such as ingenuity, hardiness, all those sorts of things that also can align with an acceptance and interest in telehealth. We see rural resilience as well. Um, and also with rural areas, we see an interest in social capital and leveraging relationships, working together, really looking at who in the community is serving children and families. So we've had a lot of uptake with school-based telebehavioral health because of some of that rural interest in schools and social capital. So I think that's a good queuing us up. It's talking about we have challenges, but we also have a lot of strengths with the communities that we're partnering with. This is my slide that really just reminds me um, telehealth has big possibilities. Um, I've seen over my 26 years providing telebehavioral health more than ever, it has the potential to care for anyone, any place, anytime. And that's really intriguing and exciting. I think with that, and part of what we'll talk about today, with those big opportunities also come considerations about how do we make sure we're translating our very best services to telehealth? How are we thinking through together some of the ethical concerns and making sure that we're providing the very best care to children and families as we look at this really tremendous reach? This is a reminder slide. When we're talking about that big reach, we really see the range of telebehavioral health. And I know in this Harborview series, you really have addressed many of these areas over time. I think in my world of child telebehavioral health, we often start off, of course, talking about that far right end with telepsychiatry and direct clinical services. Again, super important. But as we talk together today, really thinking about how can we do telepsychiatry and some of the capacity building with technologies, the remote telehub, the Project Echo, e-consults, decision supports, all of those exciting technologies that are part of telebehavioral health. And then On the more left side, looking at the technologies in green and really thinking about when we're doing some of the virtual visits and capacity building, how can we also leverage some of the facing technologies? Working with children and families, of course, we have often an excited technology group. Um, our children often, they're a digital natives, so they're looking at experience and comfort some with apps, web services, text messaging, and digital therapeutics. Of course, we want to take ethical best care when we're looking across this continuum, but we do see many opportunities and ways to reach children and families across this range of services. So we've talked a little bit about what's possible. I want to talk a little bit about what do we know so far about what's the impact of telebehavioral health. We talk a lot about the potential of telebehavioral health, including with youth and family, to look at the quadruple aim, looking at ways to improve the care team experience for that child and family, looking at ways to improve the team experience, really maximizing our health and behavioral health outcomes, and also in lowering healthcare costs. So, in terms of what we know to date, it's good news. So, when we look at the research to date for child telebehavioral health, early on, it was often a downward extension from what we know about adult telebehavioral health, really looking at equal or, in some cases, better outcomes. And we've kind of seen that thread carry through with an increasing knowledge base growing. I want to give a shout out to Dr. Kathleen Myers, one of the University of Washington pioneers in telebehavioral health. She really has spearheaded a lot of the research with child behavioral health, with one of the largest randomized trials to date around telepsychiatry. Again, really showing the good outcomes that we can achieve. Most recently, my team has done a systematic review looking at video conferencing based child behavioral health assessment and interventions. So, I want to talk a little bit about that systematic review. We presented something similar at Search earlier this year, and then the publication is under review. So, fingers crossed, we'll have this in print for y'all soon too. So the inclusion factors we looked at were behavioral health interventions with children 0 to 18 years using video conference-based interventions. Um, did exclude non-behavioral health focus, asynchronous interventions, non-video technologies, and when no child was uh, outcomes were included. Some of those studies really looked at parent impact, which is super important. We just were looking at studies for this review that also included child outcomes. So across screening, over 4,000 references, full reviews on over 360, we came down to 34 unique randomized control trials that looked at child telebehavioral health outcomes. Um, that really spanned mental health. So across anxiety, OCD, depression, social anxiety, it included interventions for developmental disorders such as autism, Fragile X, tic disorders, and others. And then we also included more our pediatric psychology interventions, so extending our behavioral health services around chronic conditions. And across telehealth settings, geographies and demographics, um, we found comparable or superior outcomes across these 34 studies, and also really found good impacts on adherence and engagement. That's good news. It gives us some reassurance that we're doing what we think we're doing with telebehavioral health. Of course, with all this work, we do really also need to look at both the short-term outcomes from these studies, but also look toward longer-term studies, looking toward research studies in the future that have varied interventions and varied populations. And then with these studies, there is always some limitations around the self-report data and outcomes. So that gives us a good foundation and good reason to be doing some of the telebehavioral health interventions you'll hear about in a minute. We, of course, look to our research when we're thinking about telebehavioral health and child telebehavioral health competencies. We look to our professional guidelines as well. This is just four of many, many telebehavioral health guidelines. If you have others that you use in your daily work and have found useful, love to hear from you in the chat about other ones than these four. I'm going to talk a little bit, especially about the American Psychological Association one in just a minute. Dr. Don Hilty, he did kind of a compilation across professional guidelines and research to look at competencies and really looked at three buckets, which are important to think about as we start providing child telebehavioral health services. Really looking at culture and making sure that the provider has the competencies with that tremendous reach that we have to see anyone, any place, just making sure we also have the clinical and cultural competency to reach out to that community. And also thinking about if it is something that we don't have currently, thinking about, well, how can we bridge that gap? Thinking about competencies with rural areas and settings, really having some uh, cultural awareness and competence around working in rural areas, and then also thinking about telebehavioral health competencies. Dr. Hilty and his team did a really nice job, especially looking at some of those more telehealth competencies. So he compared three different guidelines. I'm mostly going to just focus on what were the key areas. So if folks are thinking about starting child telebehavioral health, thinking about things including competencies in patient care, things like informed consent, thinking about cultural issues, thinking about what are the language and interpreting needs, thinking about communication competencies, knowledge and the skills and interventions delivered, thinking about professionalism competencies, practice-based learning competencies such as QI, thinking about any system-based practice competencies. You'll hear that a lot when we talk in a minute about telehealth rocks and trying to connect systems of care together. Thinking about technology competencies and technical skills, and then really thinking a lot about training. First, starting off, having some mentorship and support around telehealth, and thinking also about long-term training and mentoring together as we extend telebehavioral health services. Other competencies that Dr. Hilty and the team mentioned are some of the emerging technologies and thinking about how do we ethically include things like social media, mobile apps in the um, services that we're providing. That's kind of big picture. I'm going to boil it down a little bit more. I think this is kind of practically how I look at the best ethical practice in my own psychology work. We see that it's really aligning with the overall ethical best practices for the profession and thinking about, well, with telehealth, how does that relate to each of the areas that I'm already doing with best ethical practice? So this includes things like maintaining competence with the technology, ensuring compliance with ethical standards, providing informed consent, thinking about protecting confidentiality. That's, of course, a big one as we're thinking through reaching out with telehealth to settings that we have less control. So we'll hear about reaching out to schools and homes and how to maintain confidentiality and with our informed consent, disclosing any challenges that are unique to the setting that may be challenges with protecting confidentiality. Thinking about the same security measures that we would with in-person care, including also how we dispose data, um, thinking about any adjustments to our assessment practices that may be needed as we're extending some of our behavioral health evaluations over telepsychology, and being transparent as we're talking about some of those risks as well as benefits in our informed consent processes. And then finally, of course, complying with laws and local uh, local laws as well. Um, Again, there's often not simple answers around that. It takes a lot of talking and talking together, talking with our partners to really understand how does telehealth fit within that legal and ethical framework. Again, we've kind of gone from big picture narrowing down to kind of the summary of all those best ethical practices. And in child telebehavioral health, I think it's really nicely summarized that with individual child telepsychology decisions, we're often looking at these four key factors. We're thinking a lot about what's the developmental considerations of the child. Um, it would if you're looking at a toddler versus looking at an adolescent, we're looking at different things to think about. Is telepsych and telehealth a fit for that child? Thinking, of course, about parent and guardian preferences. Um, we saw with the pandemic a lot more um, experience and exposure with telehealth. So, more with parents and guardians, we often see a demand for telehealth, but making sure we're listening to parent and guardian preferences. Thinking about the resources for the treatment at the child site. Do we have the people and setting we need to make sure that child is safe before, during, and after the telehealth encounter? And then thinking about the behavioral health provider's comfort. Um, Really leaning into some of our literature about what do we know about um, assessing and making sure that the behavioral health provider is also comfortable in delivering the telehealth service. I'd like to take a minute here and just also hear from the audience. Um, what what's one advantage that you all may have experienced or think about in providing child telebehavioral health services, and one challenge? We'll take just a minute here. Really, again, love to hear from you all in the chat about advantages and challenges that you've seen in your practices. Isolation, that's a really important one. Thank you. Yeah, not being able to see what's in the room, another really great example. Nice to see there's both some advantages and challenges. The distraction is a good one, especially thinking about what patient population you're serving, where if you're working with kiddos with ADHD, that can especially be one you want to think and problem solve ahead of time. I think folks are speaking a little to the picture in picture function. Some kids and families prefer not to see themselves on screen. Some, it's no problem. Really well put. Thank you. Talking about the advantages, um, not missing appointments because they're able to reach kids where they're at. Yeah, thank you for that challenge. It really, I appreciate you asking the child, what do they feel about being seen over telehealth, and listening when they share that they may still not have a comfort to being seen over telehealth and feel lonely. Kids leaving the screen, again, really good one. Elopement is a challenge in person and over telehealth. Not everyone has access to the equipment needed. Great. We'll just take one more minute here. Really love all these answers. Y'all have really captured the key ones. Privacy, playing with the phone at the same time. Boy, that's when we sure see in person and over telehealth. Privacy, good, thank you. Emojis and such, good point. You all, it's great. Go ahead and type in the chat. And all these may also drive some questions that we talk together about at the end of the presentation. So if some of these weren't mentioned or there's other questions, please also enter those as we get to the Q&A side. You all have thought of more than is on the next slide. The next slide talks about some of the key ones. Again, I believe that in the chat, I saw almost all of these um, things that are advantages in thinking in a safe environment during public health emergencies, a convenient environment from homeschool or primary care where children and families are every day, fewer transportation difficulties, um, being able to see the lived environment with the family and really leveraging that to build relationship and rapport with children and families. And you also really articulated well the challenges of less control over the environment and a need to plan for behavioral and medical emergencies. Things like, again, being playing on their phone or just being distracted. How do we think about solution to that early on? Um, there is some, I'm not sure if this was mentioned again. I wasn't keeping 100% up because you all did such a nice job in the chat, but there is a potential for less formality. Sometimes that's a real benefit, but really setting the stage that, hey, we're really here to work together on your important concerns. And really, it's mostly being on the same page between child, family, and provider. Again, that's a good thing. It kind of prompts us for good communication and lots of check-ins, but that has a potential to be a challenge. Again, I really appreciate all of the chat. Really, really great ideas. I'm going to move on now. We'll continue to keep these advantages and disadvantages in mind as we talk through some of the more specific examples. Um, a question I still often get over 25 years is, can you still connect and have good relationship with children and families over telehealth? I think the key thing here is telehealth can't turn straw to gold. It really can take our best strategies and warmth and especially if we're feeling comfortable with the technologies, can really help translate that. Um, but it is something we're always being mindful. The research suggests that absolutely we can build the same good relationships, but we do need to be thoughtful about it. Um, I think there's some things in meeting with children and families. It is the relationship part, but also making sure that the other side of is good seating. Making sure it's a clinically conducive environment as much as we can to meet child and family needs. It can be things just as simple as having a sign on the door of where the telehealth's providing, just saying, quiet, please, telehealth in session, things like that, that sometimes just can get lost in the shuffle. Thinking about considering medical interpreting and some of those needs and really just asking that set of questions just as we would in person. I think the overall take home with relationship, we sometimes call this grandma's rule, and it's in the literature. It's just thinking about, overall good manners and associated best communication practices go a long way. Really, things like were mentioned in the chat, kind of checking in, asking questions, getting the client and families read about, how are you feeling being seen over telehealth. Um, so it's just a lot of practical things. It's not a one-shot thing either. I certainly make mistakes that I I made a mistake in this presentation, I made a mistake in the telehealth session, but it's not a one-shot thing. You have a chance to reconnect and say, "Oh, I talked over you. Oh, I didn't quite hear you. I didn't quite understand. Would you mind repeating that?" People respond, I think, well to that by just being honest as you're meeting over the telehealth. This is kind of in that same vein, with children and adults. It's really helpful to be on the same about what's expected in the telehealth visit. We have a little video we send out ahead of time, just saying it's often families that may both be new to the technology and may never have been seen around mental health or know anyone who's been seen for mental health. So it's just really kind of straightforward reminders and helping reassure people what to expect ahead of time. It may be things like don't show up in your pajamas, make sure your child is with you for the visit. Things that us in the profession may think, oh gosh, that makes sense. But for a family that's new, kind of having the video is super helpful just to kind of have everyone take a deep breath and feel prepared for meeting together. I'm going to talk now about a more specific example because I think it really highlights the best practices that we've been talking about. This is from my colleague Ann Davis, who she's done the telefeeding team for many years. Um, Really, she sees children and families where there's any kind of feeding concern. Um, it could be inappropriate developmental appropriateness for foods eaten, inappropriate quantity, especially under consumption. It could be inappropriate mealtime behaviors, really that whole range of feeding team concerns. I like this example because it's the whole feeding team that meets at the same time with the child and family. So it's the psychologist, the OT, the dietitian. That happens to be our KU team. Other teams really have a broader range where you may also have your physician or you may have your other specialists also meeting with the family. When they started off, they all met in one place and were all together. During the pandemic and in other times, they've often, folks may be at different places, even on the team, and are able to join the telehealth visit. With the feeding team, it really emphasized mirroring the same things that are done in person over telehealth. So the interviews are the same length. A real plus of the telehealth is being able to observe the child and parent working with the child eating. They like to joke that a high chair is part of their telehealth equipment because they really want to see that child with the parent eating so they can really provide better tailored suggestions. Um, they also do things like the diet history and record and have some questionnaires. They really lean into patient and family choice. The family often chooses telehealth because then they're able to connect with other support folks at home with them. Um, but they have the opportunity, should they choose to come in person, that's also an option. Some of the advantages with feeding team is really the convenience for the parent and family. Um, the feeding team serves a lot of children with developmental issues and delays, so not having to travel is especially helpful with those children and families. Um, and it also helps with some children who may have had some challenges and medical procedures and all that, really having that control in their home environment sometimes can be a help to those children and families. In Kansas, where I'm at, it addresses some of the weather challenges to getting in for service. It's easier to prepare their food in either their home or we've also have families present to the school setting, and other folks can join with the parents. On the provider side, there's a convenience, there's being able to see what's typically done. It's easier to link the school to other providers, and it really gives a new perspective. Really having the child and family be able to show things they're proud of in their home. Cats, dogs, brothers, and sisters is what Dr. Davis says. And it really is a plus, and it often leads to a comfort level that can help the providers do their job better. There, of course, are challenges. Some of it is making sure there's access and comfort with the technology. Um, in person, sometimes the team can help with other siblings. On site, it's harder to do that over telehealth. And it is asking the parent and to gather the height and weight information. On the provider side, it can especially be harder for OT to see some of the oral motor skills. There are extra steps in the electronic health record for some of the billing. And sometimes, again, the parent joins, but not with the student. So making sure that folks are aware ahead of time. Again, I really like this example because this is one example, but it kind of lets us think creatively. If you have a team service that you're providing children and families, it does take some creativity to think, boy, how will that translate and what can I do? It also takes some time for ramp up. With clinics such as this, I know we say usually at least 18 months to kind of ramp up and translate the child teleservice online. But I love this example because we've seen it's evolve over time and really help just so many families be seen either at home or school and get the very best latest telefeeding services. So we've kind of talked about that really clinical example. I want to make sure I spend a few minutes together talking about telebehavioral health in schools. Again, this is a really nice one where we try to catch students where they're at every day. I'm going to start off with one of our case examples, this time with a school. We worked with the Eldon district. Um, and Eldon really, about a decade ago, faced some real challenges. They were really, in terms of school performance, in the last quarter of our schools. They serve a really rural population with high poverty. Um, they were facing some challenging times in their community with some factories closing, a lot of teacher turnover, and little support from the community. So when we talk about the telehealth rocks approach, it's really trying to be a piece of solving some of the larger challenges that we see schools like Eldon face. I know we're shorter on time, so I'm not going to spend as much time on the background about why health is important in schools and the social, really just the amazing education, social determinant of health. Really, the dose response and impact for the short and long term on almost every kind of health condition you can think of, including all cause adult mortality, is linked to education. So, again, I could talk about that for an hour, but I won't. But it kind of underlies what we're doing with school telebehavioral health. Um, with Telehealth Rocks, it's that family school community partnership, and it provides behavioral health services across this MTSS pyramid. I started off with teleclinical care, which you just heard about with the feeding team example. We really extend telehealth down also to our prevention and our foundational social determinants of health interventions. One thing that's been really important about advancing this big solution has really been coming to a common mission and vision, really to keep everyone on that team together and excited to do the big things. So our collective vision is for students and families to have the exact same opportunity for success in school and in life. So everything we do kind of goes to that collective vision. We have a really large 80 plus member rural network that works on these things together with representatives from behavioral health, health, education, advocacy, of course, lots of local entities, state government, and others. We've agreed that with everything we're doing with behavioral health, it really rests on that foundation of meeting social determinants of health needs. This kind of brings that back to why is that important in behavioral health. Again, I know we're shorter on time, so I'm not going to go into this in detail. But by meeting those social determinants of health, it really leads to more options, fewer behavioral risk factors. We think it decreases physiological stress and psychological stress. So all that comes together to why we're also meeting social determinants of health needs. We place as school-based community health workers. So we employ the community health worker in the school. They use the technologies to help meet the social determinants of health needs. And then they're also really our link as we're doing some of the clinical telebehavioral health. The school-based community health worker helps support families in both learning about the service and before, during, and after the service. So another really important component is using the technology for our trainings, just like we're doing today. Um, as soon as we provide clinical service, almost immediate, we hear schools and communities also want supports in understanding how do they support a child with depression? How do they look for warning signs? I keep my brain next to my computer. We did a really fun brain health series where we talked about how does brain figure in and how does that impact child behavioral health, and how do you talk with children about brain and brain health. So again, lots of fun topics. We do a lot of education as part of our telebehavioral health. I'm gonna we have a lot of self-care topics that we address in um, in our work, especially focused on digital wellness and how we balance some of the challenges with technologies. Before we end today, I just want to circle back to Eldon. Again, telebehavioral health is just a piece of their overall community work, but we really do see in a decade by looking at these factors, they've been able to really improve their health of the community and their educational outcomes. The CHW has been essential to that. I really like how Eldon and our colleagues there frame that as rocking chair days. Just like many of the folks on this call, it's planting a lot of seeds and doing a lot of work to provide our very best behavioral health services. And we'll see that in our rocking chair days, really seeing some of the seeds we're doing now pay off and have some of the big solutions that we talked about starting out. With that, I'll end here and turn it over to Kara. I know she's going to help us with some of the questions in the chat. Thank you so
Yeah.
much.
Thank you so much, Evelyn. That was a fantastic talk, and it was so comprehensive. I feel like we could do a mini series on this with you. That was just fantastic. Thank you so much. So let's have a look at the Q&A. Um, just a note in there that the National Association of Social Workers also has a code of ethics as well. Licensed social workers can provide clinical counseling services. So that's a note from Jacqueline. And then a question, oops. How will the closure of the Department of Education affect our ability to access these overlapping programs and services? Any insights on that one?
Can you say it again? I'm sorry, Kara.
There's a question in there. How will the closure of the Department of Education that seems to be happening at the federal level affect our ability to access these overlapping programs and services?
I think that at least what we've seen so far is having the um, kind of boots on the ground support in the schools to help with doing all the pre-work, helping support during encounters and after. We're seeing just a fewer people in the school setting being asked to do more. There's both the Department of Ed changes and just real challenges we're seeing in the schools overall with retention, with retirements, those sorts of things, with some of the stressors, with the overall education systems. Again, that's just in our area. So having the person power to help during the encounter, some of that has been a little bit more challenging. There's still a lot of interest. Um, it's just more with the clinical side of things, having the person power. Um, we have seen even more uptake with our education series. I think really impressive to see your series today drawing such a large crowd. So, kind of separate from some of the stressors, including the Department of Ed changes, we are seeing a good uptake of the education side of telehealth.
Yeah. Yeah, well, I completely agree with you, and I will say that we do have such a large draw because we have such great speakers like you. Um, so I think that's all the questions that I'm seeing in the Q&A, and I don't think there were any additional ones within the chat that we missed. So again, I will thank you so much, Eve-Lynn. This has been a fantastic presentation. I think it was, I think that the small number of questions just attest to the fact that it was such a well done and comprehensive talk that covered so many areas that are really thought provoking. I often think about the digital divide issues and the digital native, and that kids seem to be so competent, but we have to check ourselves on that. So this has been just a fantastic talk. Thank you so much. Thank you to the team and to all of you who attended today. And we look forward to seeing you next month. And any of you who'd like to join the TBI Echo, I can put that link in the chat in just a second. And otherwise, I
Well, I
hope you
just
all.
want to chime
Yeah,
in how grateful I am to your team and the Northwest Regional TRC for the opportunity to chat. I know I took an ambitious approach, so I'd really love to talk to anyone who had more questions or also to learn what they're doing. Everyone is also always welcome at no charge with our Telehealth ROCKS presentations. Should be that be something folks are interested in. So thank you.
great, great. Yeah, thanks for pointing that out, actually, because I have attended a few of those and they are excellent. So I
Thank you.
encourage folks to take advantage of that. All right. Well, thanks, everybody. Look forward to seeing you next month. And everybody have a great weekend.